So I'm going to be doing an ulnar nerve neuromobilization, which is, I would do this if they have like burning or tingling or paresthesia on the side of their lateral side of their arm, and or if they have like some sort of traction or something like that, or lack of mobility, and that there is some adhesions going on the nerve. So what I'm going to do is I'm going to get the patient here in external rotation. I'm going to get them to side bend away to really put this on stretch. With my elbow, I'm going to press the shoulder down, which is really going to push the brachial plexus down. Holding the hand, I'm going to push the fingers back. I'm going to start pushing them back. It'll be at some point during this sequence where they will feel kind of a burning, sharp pain here on the outside of their arm. So I'm just going to kind of oscillate back and forth in that painful area. And now he'll let me know when the pain goes away. And then when that does, I will push him a little bit farther to get more of a stretch and release more adhesions with this. So the next thing I'm doing is the reverse slump test, which will detect adhesions, neural adhesions in the lower extremity. Maybe this person is feeling tight, kind of a burning sensation in the back of their knee when they stretch. Maybe they have paresthesia, numbness, burning, anything like that. So to start, I'm going to put their foot on the chair to kind of isolate just the one side of it. I will then have the patient sit up. I'll have them slouch forward, round their shoulders and then their cervical neck. If they haven't felt any pain yet, what I'm going to do is I'm going to press the back of the knee to the table, pump that a couple of times, and once some of the pain has started to go away, some of the tingling, I will keep them in full extension here. I will dorsiflex and invert their foot. Evert their foot. Again, do both of these until the pain goes away. Once the pain goes away, I will then plantar flex their foot and invert, and plantar flex and evert. With this, I'm hoping to see the nerves be loosened up, stretched out. There will be less pain on the back of their knee. So after this, they can lay down. They can do it again on the other side. For the plantar calcaneal nerve neuromobilization, I'll have the patient sitting up, slouched over with their neck down. Again, knee in full extension, pressing up on the big toe to elicit that pain. Once I've done that, I will extend all the toes, get this pumping in here so hopefully that nerves moves back and forth. Again, if the patient is feeling restrictions, feeling pain in their toes, that is an indication to be doing this. And what I'm looking for is just relieve the pain to be relieved, or the pain to travel up the leg, kind of a centralization kind of thing. I will do that until the pain goes away. Do it a couple of times a week as well with all of the neuromobilizations. Do this 3 or 4 times a week until symptoms improve. The next mobilization I'm going to be doing is for a patient who has limited range of motion on their right side. So that is kind of the indicator for that, is they can't turn as far looking right, or it's painful, or anything like that. So what I will be doing is I'll be starting here at the cervical joint, C7. I'm going to kind of pinch the edge, or pinch his vertebrae, spinous process with my finger. I'm going to kind of push it up like I'm pushing it towards his eye. With that joint opening, it'll allow the movement to go smoother. I'll have him look to the right towards the painful side, and then back, and then right again, and back, and then right again. 3 times. I will move up. So what I'm looking for is I'm looking to try and find, go ahead and go again, John. I'm looking to try to find the most painful spot on his neck. If I already know that, that is where I'll start. But I also want to make sure to get up and down, above and below that joint. Go ahead and turn. Yep. I'm not pressing with too much pressure, but enough that it does create opening in the facet there. And I will be doing that for 3 times on the first time. Just 3 repetitions. As he comes back again, maybe tomorrow or the next day, I'll go to 3 sets of 6 with this. What I'm going to do next is a mobilization with movement for hip internal rotation. So maybe this person is feeling hip pain. John, can you get this up there as high as it goes?
As high as it goes.
Awesome, thank you. So maybe they're feeling hip pain, they just don't have much movement. I sat them down and I see that they're rolled their leg on the table and it just doesn't rotate as well. So this is what I'll do to correct that. What I'm going to do is, once this is up as high as I can get it to the joint line, I'm going to lean back and apply pressure against his hip, just really to stabilize his hip so that my leg can move his femur to open up some space there in the coxofemoral joint. Once I have gotten that, I'll ask John, with his left leg staying still on the ground, to internally rotate. So step your right leg forward, rotate around, perfect, and then step back. Awesome. And then keep doing that. I will be moving with him to make sure I'm maintaining an even pressure around the joint, around the movement. I will be doing this for 3 sets of 10, so that way, yeah, it can really open up, and we will hopefully see a relief of symptoms as well as a greater rotation in this movement.